This vent, and then we'll just kind of go through. So let's talk about let's say that we have a patient, and let's just kind of run through a scenario. So let's say that we had a patient that was they're in volume control right now, okay, and they came in. You had these initial settings, okay, and then you get called to the bedside because the nurse is telling you that the patient, something's going on and their peak pressures are getting very high. Okay, so they have high peak pressures. So what does that tell you? Like first off, what are some things that you can do? Yeah, airway, clear the airway. So several things can be happening, right? Something in the circuit is pinched, or they could have resistance, or they could have secretions. They could have just be coughing. So let's say that you continually, if I came in and I suctioned, I gave a neb, but they were still having compliance issues. One of the other things I could do is kind of go up on my PEEP to try to get a better FRC, see if I could get a better compliance to where we're not using as much peak airway pressure. But let's say that the doctor, now the doctor wants you to he wants to try Bilevel because he's okay. This patient they were in a motor vehicle accident. They had a bunch of pulmonary contusions. He told you, he looked at his x-ray, and now he's seeing that he's starting to get some, you can see it even on his chest. Looking at his chest, you can kind of see some bruising. He hit his steering wheel, so now he's probably has some leaky capillaries, everywhere. So the doctor wants you to go ahead and try Bilevel. Let's say we've came up our O2, well, I'm not going to change it now, but let's say our O2 has kind of went up. We're at like 100%. We've raised our PEEP. We're at a 10 a PEEP, and we're still not getting a good change. And you're working with Marinero, and he wants to switch over to Bilevel. He wants to just get this patient primed before they start going atelectic, and he knows that they have chest injury, so he wants to kind of start utilizing Bilevel. So, why don't you go ahead and just, do you want to do it, or somebody come in here and just make changes to the vent to go into Bilevel?
Karina.
Oh.
So one of the things that you want to be aware of, remember our peak pressures that we're getting are about 34. So we want to be a little bit below that, right? 75%. You want to kind of be below that. Obviously we want to be at a P high of about 30. If our peak pressures are already high and we're getting that volume, you know that when we go over to Bilevel, we're still going to need probably a good P high of at least 30. We want to stay below that. Our PowerPoint said, use as high as 35. But I would start out a little lower.
30 around?
Yeah. And see where you're going to be. So you can see what's going on here. You have a rate of 16, and let's say that that's been adequately ventilating the patient, like their CO2 has been okay, but their oxygenation is now dropping. We're at 100%. Their PO2 is really crappy. You send off a gas, and they're coming back at like 50. So the doctor wants to switch over. So go ahead and switch it over to Bilevel. So let's say that he didn't give you specific orders, but looking at what you have set, you're going to kind of see where you need to be with Bilevel.
Which one's this one?
So remember, so this is Bilevel. It's on this vent. It is Bilevel. It's not APRV or Bilevel. It's Bilevel. So here's our Bilevel screen. Okay, so the patient is still getting ventilated. We want to set our Bilevel settings. So we know that our peak pressures being generated are pretty high to get that tidal volume of 500. So I would start out, because you know that your peak pressure is 30, or 30, it was like 35 before. You want to start a little closer to 30 to see what you're going to get. So you can, so go ahead and set your P high.
To what?
30?
So let's start at 30, yeah. What do we want to do with our PEEP?
Zero.
Yeah, you want to go to 0, right? Even though we were using 10 of PEEP, obviously we're not going to utilize the same mode of ventilation anymore.
Now, why do we have our P high set at our peak inspiratory pressure?
Well, I know it was 13. We were like 35, so I wanted to go a little bit lower than our peak inspiratory pressure, like 75%.
Go over, say to set it at your mean airway pressure, though?
You could set it at your mean, but this mean is going to be pretty low.
Okay.
Yeah, because we're in volume.
Okay.
So with adults, you really want to go like 75% of what their peak, peak inspiratory pressures were.
Okay.
Yeah. With neonates, you're going to kind of stick to that mean airway pressure.
Okay.
Yeah. But again, what else is going to dictate that? Like, let's say that let's say I went to 20, and what am I going to look for now once I get that change? What's going to kind of dictate my P high as well? Not just my peak area pressure, but what else? What tidal volumes we're getting back,
Tidal
right?
volume
Once we
when
switch
you're
over, if
releasing
our
it.
tidal volumes are too low and it's
Then
not
you're gonna
adequate
go
for
up.
him, we're going to have to go up on our P high. Or if it's too big, we're going to come down to
down.
an appropriate tidal volume. But it just gives you a ballpark of where to start.
Okay.
They said it's PaO2 is only 50, so being at 15 is
It might, yeah, it might not. So, yeah, but it, it all depends on what their, what their compliance is. Again, it's just kind of a where to start. But just be aware that, like, really you want to have appropriate tidal volumes because that's going to become very important in this mode. So then your T high, where do you want to start the T high? So remember, we want to be, T high is going to give you, at 2 seconds, is going to give you a bunch of releases. Okay?
Oh,
so
and
if I
that's
press
gonna
that,
increase your mean airway pressure.
yeah,
so,
so
you wanna go up.
we want to, you usually want to start out at least above 3. And remember, with this band, you're setting the T high directly, so your rate is going to change up here with whatever you're setting for your T high.
Can I do
So the
like
higher you go, the lower your
3.5?
rate is. Yeah, that's fine. Obviously, we want to kind of
Yeah.
look at where the patient is. If the patient is not spontaneously breathing, we're probably gonna have to shorten that because we want more releases. If they are spontaneously breathing, then so it's all going to depend on where once we get the set, check a blood gas, see what the patient is doing. There's a lot of factors that go into what you're setting.
Don't you technically want a 1-to-1, like a true?
Not on
Inverse
this.
ratio.
Not on this. You actually want
A longer
inverse. You want a longer
inspiratory.
inspiratory time.
And then
Yeah.
the shorter. Okay,
Yeah.
sorry. Yeah.
He
So
said
let's
there
say
was
that-
sometimes that they did do it like that.
Okay.
Yeah. So, given that we're not really going to worry too much about the respiratory rate at this point, because if that patient is spontaneously breathing, they're going to be probably breathing in the 30s. Because if you look at what their spontaneous rate is on top of this, it's going to be, usually they're going to be a little bit tachypnic. But that's okay. You want them spontaneously breathing. So, let's say I'm going to just go ahead and set it at 5, okay? So you can see where it's just going to bring the rate down, but we're going to kind of optimize our mean airway pressure. And then our TP, where do we usually want to be? A good place to start is like about 0.5 and then measure and see what's going on, what their compliance is when you actually measure it.
You want me to do 0.5?
Yeah.
And that's the P-low? Just
TP is
It's
your TP
T-
is the time at your P low.
P-low.
So this is your P low, this is your
zero.
pressure, and this is the
The
time that
time.
you're spending there. Does
So
that make sense?
Jose, I still don't understand why our peak is 0. Why don't you put it up to 4 or 5, whatever?
Because see what you're doing, and I'm going to just shut this off for a second. So let's say that we went into this mode. So let's look at the graphic, and maybe that'll kind of clear it up a little bit. So you can see if I set a PEEP right now, because I'm releasing, I'm doing a release. I'm actually not even going to get down to 0 pressure. My PEEP, my residual PEEP, is still maintaining at about 4. Because what's happening is our release time is so short that we don't actually
to
let the
baseline.
alveoli collapse. So we have some residual PEEP that's left in the alveoli.
Okay.
Go ahead. Yeah, so usually if we can't create that residual PEEP, let's say that, so here's the mechanics of it. If my lungs were so stiff and they recoil really fast on expiration, and I don't know if I can mimic it, but if they recoil really fast on expiration and no matter what I do, I'm releasing more than 30 to 40%, I might have to set a little bit of PEEP.
So it won't matter if I set a peak of 3 unless it comes to that. It's essentially a backup peak.
Yeah, essentially, but what you can't, but the whole purpose of this is to maximize your deflation as well. So usually we're not going to set it even as a backup to it. We're just going to leave it at 0. But yeah, I see your point. You're saying like as a kind of a baseline so it doesn't get past that.
But it's constantly evolving.
Yeah, yeah. Okay, so usually if the patient, obviously I can kind of take spontaneous breaths, so you can see that T that's appearing there on the screen. So I'm taking some good spontaneous breaths there. And then I'm going to get the releases no matter what I'm doing, okay? So let's say that, like on this mode, sorry, let me just change this. It's not screen as. Okay, so let's say that that you have the patient in this mode. They're on 30. Your tidal volume for this patient, let's say, is appropriate for them. It's like reading about 500 on their. Let's see if it's reading about 500 on their dumps. About 460. So let's say that I didn't have enough. So let's say that my tidal volume was too low. How am I going to increase my tidal volume?
Your tidal volume.
Increase the
Wouldn't you go up on your
rate.
Go up on what? Yeah, your P high. So the higher you go on your pressure, the more pressure you're applying to the lung. So on release, you're going to actually be releasing more. So if your tidal volume isn't high enough, you can go up on your P high. The other thing that you can do secondarily is adjust you can adjust your TP, but you usually, once you get that ideal, you don't want to change that. But technically you're going to have more tiny release if you change your TP, so your overall tidal volume might increase. But usually once we have this set, like I mentioned, we don't want to change it. But once it's ideal and it's at 30 to 40% release, we don't want to change it. So if we need to increase our tidal volume, we're going to go up on our P high. If our tidal volume, let's say that they become really compliant, they got a bunch of Lasix, all of a sudden they're getting big tidal volumes of like, I don't know if I can mimic it or not, but let's say that he's getting big tidal volumes of like 800. What do I want to do?
P high?
Then I'm going to decrease P high. Okay?
It's the same concept as delta P.
Yes.
Right?
Yeah, it is pretty much. This is a pressure-based mode, so yeah, it's the same concept. So how about if let's say that I drew a CO2 and now I'm having a problem with CO2. So let's say that my CO2 came back and my CO2 was now 65 and the physician wants to get it lower.
You want to increase your TP so you have more expiratory time.
decrease?
So think about that. Let's go back to the screen.
Decrease.
So if I want to blow off more CO2, what do I want to do?
You're going to shorten your increase your respiratory rate. I'm trying to think of what you adjusted.
Right. So I want to increase respiratory rate, right?
Increase that,
Because I
then
want
you
more
decrease the
minute
T high.
ventilation. In this mode, what do I do for that? I'm going to decrease my T high. It's going to spend less time, so I'm going to have more releases per minute.
Could you titrate then this to higher? The
You
expiratory
really,
time?
well,
Or not? It's
really,
separate.
once you have that set, you should leave it alone because you want an appropriate release and you want to leave that alone. So if you're having a CO2 issue, you want to shorten that. So if I shorten this, I'm increasing my overall rate. Does that make sense?
Mm-hmm.
Okay. Does that make sense? So CO2 issue, shorten your T high. If I'm blowing off too much, then I'm going to actually make that higher, right? But remember, the lower we go on this, we're giving up mean airway pressure. So if I make a really drastic change, what might happen to my SpO2 or my PaO2? It may go down because you're giving up a little bit of mean airway pressure. Does that make sense?
Yes.
So that you're kind of having to balance the two of them. So look at what my mean airway pressure is here. It's like at almost 30, right? So you can imagine what that does with your intrathoracic pressure. That's why I had mentioned, the patient has to be kind of volume-wise. They have to be kind of titrated with we have to give them more volume usually because we want to have their pressure appropriate, their blood pressure appropriate. Again, you can set the pressure support. We usually don't. The inspiratory rise time, it defaults to 0.15. We usually leave, you can kind of adjust these to the patient. They really, in this mode, it really doesn't matter too much because they're barely taking spontaneous breaths. They have such a huge FRC that they're not going to make too much of a difference. Your rise time, you're just going to go up to pressure right away. If you hit 0, you're going to stretch, you're going to ramp it a little bit more with your rise if you increase it. Yeah.
Your trigger, which you want to make it easier for them to trigger?
Yeah. So on this vent, which way is making it easier for the patient? easier. So if I want, let's say that I look at the patient and he looks like he's working hard, and
Which one to lower it?
how am I going to make it easier for him to trigger a breath on this vent?
I think it's higher, isn't it? Because if it's in
You're
the
going to
red,
go
it
higher.
self-triggers.
Yeah, this
Okay.
vent is kind of opposite from that one.
Yeah.
So you're actually going to make it higher. This is going to make it more sensitive to the patient. So once you get above 7, you can see where it goes red, because it might become so sensitive that it's like any movement in the circuit is going to trigger the vent.
That's cycling, right?
That's auto cycling. Yeah.
That's because
So-
the bias flow is.
You're just changing the bias flow a little bit. Yeah. So.
Bias flow is like 8.5 or.
So actually on this vent, I think it's like a consistent 2, I want to say 2 liters.
I think 840 is the 8.
Yeah, the 840 is directly like you're actually changing the bias flow. On this one, I think it's consistent. And this is just a percentage of what the bias flow is. So the higher you go, the actual more sensitive it is. The lower you go on this vent, remember, with your sensitivity, if you go down to 1, if you go down to 0, look where I'm at now. Now I'm in pressure. So if I actually, the more lower I go in pressure, the harder it is for the patient to actually trigger a breath, because they're having to generate a bigger negative pressure. Remember, on the 840, you actually change it over to pressure, or you change it over to flow, right? On this one, it's actually in the same block. Does that make sense? So technically, the higher you go on this, the easier it is for a breath, to trigger a breath. Okay? Usually 3 to 5 is kind of where you want to be with this vent. Does that make sense? Okay, measuring. Do you guys remember how to measure? So remember, if they say, okay, let's